شكرا. بس just a minute يا بروف. Some arrangements. تمام طيب. اوكي طيب انت بديت الريكورد ان شاء الله يستارت يا بروف ان شاء الله.
اي تفضل يا تيسير، تفضل يا تيسير.
طيب بسم الله الرحمن الرحيم، السلام عليكم ورمضان كريم وتقبل الله منا ومنكم صالح الأعمال. I'm Dr. Taysir Kashif, Director of Al-Tababa Advanced Training Center. I very much believe that you have to take advantage from the others' experiences. You will not have time to go through them all. I'm very happy to be with you this night and happier that we are sharing this night session which comes within the framework of Al-Tababa Ramadan Nights اللي احنا بنسميها ليالي الطبابة الرمضانية which completed its first anniversary this Ramadan. It's a good opportunity to thank all our teachers who participated with us and were the reason for the success of this pioneering project, the expatriate online sessions. Actually, it's so rare to repeat a session that's being given before that this is the first time we have done this. I would like to welcome you all again in Beating the Beast, best current pharmacological modalities for treating COVID-19 infection by Professor Imad Hassan. Professor Imad, MD Immunology from UK and has a master's degree in infectious diseases. He is a fellow of the American College of Physicians and has a fellowship of the Royal College of Physicians of Ireland. He is a head section medical protocol department, Kingdom of Saudi Arabia. We'll take all your questions and queries after the session by using the raise hand option on your screen. Professor Imad, your stage. تفضل Prof. Imad.
السلام عليكم وكل عام وانتم بخير وربنا يتقبل منكم الصيام والقيام. I'm glad actually to share with you this presentation, actually the second time, a bit updated from the previous one. So I'm actually have made some changes to the previous one to make it more practical for the people. Right, I'll start my session now. Right, I'm sure you will actually enjoy the session and find it very useful. Right, now beating the beast. So I'll be actually focusing on the pharmacological modalities for treating COVID-19 infection. Right, these are pictures from the beginning of the pandemic in Sudan when people were preparing healthcare workers to preparing them for fighting the epidemic or the pandemic. Now the aim of my presentation is actually only one, is to empower whoever is actually attending this session with the current effective therapeutic modalities. Now I'm basing these on systematic reviews of these interventions. So I'm actually focusing mostly on what is based on systematic reviews rather than on just randomized or observation control studies or observation studies. And I'll explain to you what I mean by a systematic review later on. Now, we should really, at this stage of the pandemic, we should really work towards zero mortality for COVID-19 infection, not only in Sudan, but all over the world. The current evidence is strong enough to stop this carnage, this unbelievable killing this virus is causing, is resulting in. Now, let me just amuse you with one historical fact, and actually I hope actually the COVID-19 pandemic is not just a repeat of what has happened before, repeating history, as they say. Now, this is all about thrombolysis for acute myocardial infarction. Now, thrombolytic therapy now is considered a cornerstone, a basic undertaking in treating patients with acute myocardial infarction, right? Together with, percutaneous intervention and so forth. Now, let me just share with you these facts. Now, the first thrombolytic therapy, the first one was actually conducted in 1958, right? Now, in the 60s and 70s, 24 more other trials were performed, all looking at evaluating the use of streptokinase or thrombolytic therapy, for myocardial infarction. Now, these had contradictory results. Some were positive, some were negative. So what did people do? Right, just stop doing any more trials. right? Because they said the results are contradictory. Not only that, they stopped using thrombolytic therapy for acute MI, right? It wasn't until actually the late 80s, early 90s, when big studies were undertaking, the issue was revived again in big international studies, and the evidence became very powerful, and then they were finally included in the guidelines in the 90s, right? An unbelievable, staggering delay of more than 25 years, right? From 1958 to when it was formally included in the guidelines, right? When people calculated the amount of the human cost of this delay in applying the evidence, it were actually millions of lives of people with MI, right? From the late 50s to the early 90s, right? When the guidelines actually formally included thrombolytics. A very sad story. I hope that we are not going to repeat history again and see it happening with the COVID-19. Now, my talk is in two parts. The first part, I will just share with you some background information about the pharmacological, some background information that we need to know to appreciate, the treatments that we're going to, pharmacological treatments that we're going to offer the patients. And the second part is actually about the recommendations based on the current evidence, right? So the challenge and the background knowledge, these are the two parts I'm going to start with. Now, let me tell you about a story, right? A story that really needs to be shared with everybody. Now, the story of Saudi Arabia and COVID-19. Now, as of yesterday, there were around less than 500,000 cases, right? The number of people who died, actually, around 7,000 people. For me, this is a big number. For a country like Saudi Arabia, in a world that having millions of deaths or hundreds of thousands of deaths, this is a major achievement. Their case fatality rate is 1.7%, and they managed to keep their case fatality rate and the numbers down because of leadership and the good quality of healthcare they're having. Internationally, as of yesterday, 146 million cases of COVID-19 were documented, a staggering 3 million deaths, an unbelievable 3 million deaths. The case fatality rate is 2.1%, right? This is actually, compared, for example, to the flu, is actually almost 20 times or more, right? It's very high for a viral infection. An unbelievable 3 million people died of COVID-19 in just over a year. Looking at the story of COVID-19 in the hospital, and this actually matters a lot. Now, this is based on a systematic review and meta-analysis, right, which was published last March. If a patient goes into the hospital, non-ICU, general ward, the chances of dying are actually almost 1 in 10 or a bit more, right? 1 in 10 people going into hospital are going to die from COVID-19, an unbelievable number. This number goes to close to 40% or more. You can see the range is 31 to 50. Almost half of people going to the ICU from COVID-19 are going to die in the ICU. Again, a very sad and unbelievably sad story. Right. Now, let's maybe just remind you of the important things and important knowledge that we need to know so that we actually improve our understanding and management of COVID-19. Now, I will just mention a few things about the pathogenesis of COVID-19, prognostic markers, evidence pyramid, what is a systematic review and meta-analysis, what is a network meta-analysis, but very briefly, just to bring you into the, so that you can have a better understanding of what I'm going to mention. COVID-19 is a simple viral infection, right? It's primarily affect the respiratory tract, right? So people coming with upper and lower respiratory symptoms, right? Classically, in some patients, it will progress to a viral pneumonitis, primarily an interstitial infiltrate bilaterally, primarily peripherally, which actually progresses over very quickly over only a few days. You can see the X-rays just worsening in front of your eyes, over the few days. On a CT scan, The ugly looking ground glass opacification, primarily peripheral, you can easily see in actually on a CT, classic of this new or novel infection, COVID-19, right? COVID-19 is not only a respiratory disease, but it also is a systemic disease. And you can see every part of the body might be affected: the brain, the heart, the kidneys, the liver and gastrointestinal tracts, the blood, and so forth. So you end up with actually a systemic disease as well as a local or pulmonary disease. A very important concept, right, when dealing with COVID-19. As a matter of fact, if people are not aware of this, right, they are unlikely to provide a full comprehensive package of care, right? COVID-19 is a phasic disease. It comes in phases and then stages. Now, you need to actually treat according to the phase or stage of the disease. You cannot treat, you cannot just say a patient coming with pneumonia, you give an antibiotic at any stage of the disease. No, COVID-19, you have to decide what is the stage of the disease you are seeing the patient, right? And deal with that patient with stage-specific interventions, right? The phases are two. There is a preclinical phase and a clinical phase. Now, the preclinical phase is the phase that happens post-exposure, usually a viral replication phase, right? Average duration, or the incubation period, is actually 5 days, 1 to 14 days, maybe slightly longer in some studies, but this is the usual 1 to 14 days, right? And then comes the illness itself, the disease itself, and it comes in stages. The first stage is actually is just a simple viral infection with or without interstitial pneumonia. Usually takes the first 5 or 7 days, right? If patients deteriorate, they will end up being admitted by day 7 onwards. And this is stage 1. Stage 2 is the hyperinflammatory or pro-inflammatory phase. And usually it comes following 5-10 days. So end of the first week going into the second week, right? And this is an immunopathological phase where people can go on to develop ARDS, adult respiratory distress syndrome, or a cytokine storm. We move on, and then patients can develop another stage of the disease called stage 3, which is the hypercoagulability. Now, the hypercoagulability, usually second and third week onwards, second to third week onwards, and then this stage can merge with the second stage. And the last stage is stage 4. This is the post-COVID syndrome, the long COVID. And now people are saying that at least 1 in 5 patients who develop COVID-19 infection will progress to have long COVID, right? This diagram, illustrates this: the pulmonary phase, the pro-inflammatory phase, and the prothrombic or hypercoagulative phase, right? And the pulmonary phase, the pneumonia and interstitial pneumonitis. The pro-inflammatory phase, you have acute lung injury and the cytokine storm. And the prothrombotic phase, when you see coagulopathy and multi-organ failure. And you can see that these stages actually merge with each other, right? So the second stage, where you have the pulmonary phase, you will end up actually having, some of the viremia there and some of the inflammation at the same time. But as the disease progresses, you move on to the inflammatory phase, away from the viremic or viral phase, right? And in this phase, obviously, you start seeing again the hypercoagulability phase, right? And so they merge, the viral and the host immune response merge with each other, right? And every phase has its own markers. Every phase has its own markers, right? And I've actually simplified it in this schematic diagram, right? The preclinical phase, obviously, the patient is asymptomatic, may have a positive PCR or not, positive or negative, and they are usually in the community. The stage 1, this is the viral infection, and they develop, what might look like a simple flu symptoms with or without pneumonia. They are PCR positive, but they have a flu with or without pneumonia, and they are usually in the community or in the general ward. Now, going to the hyperinflammatory phase, then we start seeing the change. We start seeing a significant increase in the inflammatory markers. They have started here, but now they are significantly raised, like the CRP and interleukin-6. The X-ray is worsening, and the patient starts to desaturate. So the markers of this phase are the high CRP and the desaturation, right? And these might still be in the world. Usually when people do go onto coagulopathy, they have deteriorated so much they have actually gone to the ICU. The markers for this phase are the high D dimer and obviously positive Doppler of the legs or a CTPA or somewhere else. You can develop, patients can develop cerebral sinus thrombosis or any thrombosis anywhere else, or a stroke or an MI. So this is the stage of coagulopathy. And then obviously the post-COVID syndrome, which if patients survive, they end up with residual issues later on, either in the hospital or in the community. Now, I wanted to highlight here that the markers for the inflammation and coagulopathy phase are actually only, the two major ones are only the CRP and the D dimer, right? If you really want to know where is the patient in his illness, you need to monitor the CRP and the D dimer if you want to know, have I entered the coagulopathy? It's important to know that the pathophysiology or the pathogenesis of the high CRP is different from the pathophysiology of the coagulopathy. They're not the same. And we have seen patients CRP, improving while the D dimer going up, right? The illness is still, the disease is still active, but the inflammatory phase is actually resolving, right? And we have seen this, and it's well documented in the literature, right? If you see the D dimer going up, the CRP actually going down, then you start really thinking that, oh my God, I have some coagulopathy going on. Now, just to remind the people of some important risk factors, and as you all know, the comorbidities are the major risk factors. But importantly to mention that male, gender, and age are other major risk factors, right? They dramatically, especially age, dramatically increases the seriousness of the disease, right? Obesity is another one, right? Which really, obesity makes really is a major risk factor for a significant or worse prognosis, right? And when you look at the age is really the most important risk factor, right? If you look at age, right, you can see that young people, hospitalization, ICU admission, and case fatality, right, significantly increases as people get older. And as a matter of fact, although, for example, the people from the age of 60 to above 60, they might only beat 36% of cases, but as a matter of fact, they almost 90% of deaths. So once a patient actually, age is above 60 or even above 40, then you start having problems. Right, but it seems that the cutoff age is really 60. So 60 plus is it's very serious in COVID-19. Now, just to mention a few things about these EBM concepts that are very important for us to know as physicians, and so that we can apply the right evidence for our patients, right? When we say something, when we use the term systematic review and meta-analysis, we mean is the highest level of evidence. Now, this is called the evidence pyramid. And so they say evidence is not all equal. So systematic reviews and meta-analysis are the top of the pyramid. So if somebody tells me the result of this study is based on a systematic review and meta-analysis, the result of this intervention is based then, and it becomes more believable. I should believe it more than just if I look at a randomized controlled trial or a cohort study or an observation study and so forth. So when they say the use of this drug is based, the use of this class of drugs is based on a systematic review, right? And then it's more relevant and more trustworthy than if I say it's just based on a randomized controlled trial, right? And just to give an example of a practical example. Supposedly, I have so many ACE inhibitors used for the management of heart failure with reduced ejection fraction, okay? And some of the studies are showing, mortality benefit, and some are showing no mortality benefit, right? So people with heart failure, some say ACE inhibitors work, some say ACE inhibitors don't work. So what am I supposed to do, right? Say, just like this thrombolytic therapy, I say, well, some are positive, some are negative, just ignore it, and I don't want to use them, right? This is the beauty of systematic reviews. Systematic reviews goes on to select the best studies from all the ACE inhibitor studies in heart failure with reduced ejection fraction, select the best studies, appraise them or make sure that they are actually valid, they are scientifically valid, they use the right way of doing the study, right? And then put them together, come up with one conclusion, right? Selecting the best studies, coming up with one conclusion. And this is the beauty of systematic reviews. If people in the 60s or in the 70s knew how to do systematic reviews, they would have started using the thrombolytic therapy earlier on. Now, sometimes these studies, for example, I found 20 studies on ACE inhibitors which were good enough. So I take all these 20 studies, put them together, and even pool their data together, come up with one conclusion. This is called a meta-analysis, because I have used all the data, the mathematical data, to come up with a new figure, and this is called systematic reviews meta-analysis. That's why they say systematic review with meta-analysis is the best or highest level of evidence, right? Just briefly to mention that there is something called the grade. Grade is actually stands for grading of recommendation, assessment, development, and evaluation. It's a very simple tool to assess the quality of evidence. And if they say this study is based on a very high level of grade, it means that this is a 100% trustworthy study. And people have used the grade system in 4 classes to divide the studies into 4 classes: high, moderate, low, or very low. If a study is said to have a high grade or moderate grade, then probably you should really use this intervention. If it is low or very low, it means that you are not confident that the effect is right, and you probably need to do more studies. Right. Now let's come to this, outstanding study, which was actually published in December 30. Now, these are Koreans who actually published this study. What did they do? They looked at all the pharmacological interventions that have been actually been employed to deal with the COVID-19 infection, right? And instead of doing one class of intervention, for example, only looking at steroids, they also looked at steroids, at tocilizumab, at chloroquine, at azithromycin, right? They looked at all the interventions. All in all, they managed to look at 46 interventions, 46 pharmacological interventions, right? They based their actually study on those who are hospitalized, either with moderate to severe disease, right, who've come to hospital. They did not look at patients who are in the community, right? And they focused on randomized control trials and observation studies. And obviously, they were focused only on adults, right? There were 2 classes of patients: those with moderate to severe patients, right? These are out in the ward. They did not need ICU, or they were not in ICU. And the critically ill patients, those are the ones who actually received invasive mechanical ventilation, or at least needed some intensive care in ICU, for example, inotropes, right? So they looked at only patients with moderate to severe disease or ICU patients. They did not look at patients who are actually being admitted to the general ward. And as I mentioned, they looked at 47 pharmacological interventions, all, over the last year or so, right? There were thousands and thousands of applications on interventions, pharmacological interventions for treating COVID-19. The total number of patients in these studies for these 47 pharmacological interventions were actually close to 50,000 patients, right? Now, this is a diagram which tells about this sort of called network meta-analysis. What it does, this is the placebo arm, and this is a study between the placebo and high-dose steroids. And this is a study between placebo and hydroxychloroquine and azithromycin. This is a study between placebo and IVIG. So you can see these are all interventions for pharmacological interventions for COVID. This is a placebo against remdesivir, right? The thickness, why is one thicker than the other? Because the thickness tells about the number of studies. The thicker the line says that there are more studies in this category, placebo against remdesivir. For example, here, this is a very sick line because there are so many studies between placebo and azithromycin chloroquine, and so many studies between placebo and hydroxychloroquine. Now, this is called the network meta-analysis diagram, which just gives you a picture of how many interventions that have been done and how many of them in total for each specific intervention. As you can see, unlike a systematic review where you look at only one class of drug, ACE inhibitors in heart failure with reduced ejection fraction, here you are looking at so many drugs all at once dealing with the infection, right? So you are doing something called a network meta-analysis. Now, when they looked at random, this is just to give you an example, when they looked at mortality for moderate or severe COVID-19, these are non-ICU, the only drugs which seem to have worked in patients in the ward are remdesivir and corticosteroids. So when patients are in the ward, remdesivir and corticosteroids are the ones which really worked, right? People actually who are conversant with evidence-based medicine will know that this is called a forest plot, and this one is the no effect line. So any study has a confidence interval, which is the horizontal line. Any study which crosses the no effect line means that this study showed no benefit at all, right? So this study, right, using 3 antiviral drugs, this is the confidence interval, it's crossing the no effect line. So you can see it actually suggesting that it didn't give any positive result. However, the study, for example, with corticosteroids, this is the one, and the confidence interval is 0.66 to 0.91. So it's actually not touching the 1, which is the no effect line. If it was going to 1 or 1 plus here, it means that it's crossing the no effect line. And in this forest plot in the systematic review, right, you can see that remdesivir and steroids are the ones that really worked in the ward, right? And when they looked at other studies, these are the observation studies, these are not the randomized studies. And you can see that remdesivir, convalescent plasma, high-dose steroids, tocilizumab also worked, right? You can see these are not touching the no effect line, and therefore they're suggesting that these are working, right? So, and there are also high-dose steroids and interferon. There are many drugs which showed benefit in actually improving outcome based on observation studies in the ward, right? There are many interventions that are there, right? I summarize all of these network meta-analysis findings just for the sake of making it simpler, right? And what are the drugs which reduce mortality in the non-ICU setting? These are primarily steroids and remdesivir. This is anti-hepatitis C drug. There are at least 3 studies showing that it actually works in reducing mortality in the ward. And for observational studies, there are so many other interventions like steroids, tocilizumab, interferon alpha, anakinra, and high-dose steroids plus tocilizumab. But you can see these are considered low-level evidence. But on the whole, these are all interventions which seems to have worked in the ward to reduce mortality, right? The question is, how many of these are we currently using, right? In an ICU setting, there are at least 4 drugs which seem to have reduced mortality in ICU setting: steroids, high-dose IVIG, and tocilizumab. Also ivermectin. How many of us are using ivermectin in the ICU setting? The grade is low or very low. It means that it is not as trustworthy as, for example, the steroids, right? But this is a grade, and I'll tell you, several of the streptokinase studies for thrombolytic therapy, when people use the grade, they also came up with very low. And now streptokinase or thrombolytic therapy is a must in the management of myocardial infarction. It doesn't mean that it is very low, that we should just put it in the bin. We should really say that this is a signal. The signal is a bit on the low side, but there is a signal that ivermectin does reduce mortality in the ICU, together with tocilizumab, together with steroids. And again, this is an important thing, progression to severe disease, because progression means that people are going to go to the ICU. So what are the interventions which can reduce progression of patients and reduce admission to ICU? This is very important, especially in a country like Sudan. We don't have ICU beds. Come on, we don't have enough ICU beds. So what are the things which work? You can see steroids, high dose and high dose and high dose, right? High dose steroids really do work. And a matter of fact, only yesterday, Dr. Muhammad Al-Fatih, one of Tababa members in Khartoum, sent me a study about high dose steroid. But we know that higher dose steroid, even higher than what we use now, the 6 milligram of dexamethasone, it probably works better than the low dose dexamethasone, like 6 milligram of dexamethasone. But high dose steroids, remdesivir, right, do reduce actually progression to ICU, progression in disease progression and admission to ICU. If you look at observational studies, also we have evidence that tocilizumab, convalescent plasma, baricitinib, and anakinra, and by the way, anakinra is available in Sudan, right? Although the grade is supposed to be low, but these are actually based on observational studies are also working. They also reduce progression, right? When they looked at what makes the patient PCR negative, although I don't believe PCR negativity or positivity means a lot in somebody who's admitted with COVID, because we know that they remain positive for ages and they are not infective anymore, so they might be a dead virus. But anyway, there haven't been many studies which show that any specific intervention really reduces the positivity rate within 14 days. Right. Now, when they looked at the hydroxychloroquine and azithromycin, right, they actually came up with a clear conclusion, right? They are actually just cause serious side effects and fatal cardiac complications. And you can see this is a significant side effect, right? About the other drugs, the steroid, the tocilizumab, remdesivir, ivermectin, whatever, no drug was significantly associated with increased non-cardiac serious events. So these others are actually safe with no serious non-cardiac events, right? Their conclusion was that for people in the ward, steroids, tocilizumab, anakinra, remdesivir, and convalescent plasma, they reduce the risk of progression to severe pneumonia, admission to ICU, and or mechanical ventilation. Steroids and remdesivir further showed survival benefit, right? So steroids and remdesivir also improved survival benefit. So these interventions were sought to reduce ICU admission, and these interventions were sought to also improve survival, okay? In the ICU, steroids again work to reduce mortality in the ICU, okay? And ivermectin, tocilizumab are also helpful there. They also will reduce mortality, but these are based on observational data, right? So ivermectin and tocilizumab in the ICU. Hydroxychloroquine out, not shown to reduce mortality rate or even progression to severe disease, right? Their big conclusion, right? The big conclusion was that once a patient goes to hospital, anti-inflammatory drugs are the ones that probably improve survival, right? And it seems that steroids, tocilizumab are the ones which really work, okay? And they are saying that, okay, in the ward, managing the inflammatory response is very important, okay? But now, their meta-analysis, the network meta-analysis, unfortunately, missed at least 3 other drugs, right? We know that, COVID-19 has a hypercoagulability component there. They didn't include any of the anticoagulants. And I actually tried to find out why they did not bring in the meta-analysis. They didn't mention anything about the anticoagulants, right? They didn't mention anything about vitamin D or doxycycline, right? Despite the fact that there are some suggestions that vitamin D does work, anticoagulants are important. Now, let's look at this hypercoagulability issue, right? This is again a systematic review, March last, 2 months ago or less, last month. They looked at 33 studies in a systematic review, again, a systematic review and meta-analysis, right? They found that venous thromboembolism, almost 10% overall, If they go to the ICU, 1 in 5 develops a thrombus, right? So very high rate in the ICU, 50 or 20%. 1 in 10 will develop thrombosis. 1 in 10 patients with COVID-19 will develop thrombosis, right? And in the ICU, it becomes 1 in 5, right? So doubles when people go into the ICU, right? They also highlighted that there is a high prevalence of thromboprophylaxis failure, right? Especially in the ICU. But I have seen thromboprophylaxis failure in my patients in the ward as well. So it doesn't have to be in the ICU, but it's more in the ICU. So simple thromboprophylaxis doesn't seem to work in the ICU, right? Now, again, another pooled analysis, a systematic review. Again, they looked at all on 35 observational studies, right? And they looked at venous thromboembolism, right? If a patient is admitted and has no prophylaxis, almost 40% develop thrombosis. If they are giving standard dose prophylaxis, they go down to 20%. It doesn't come to zero. If you give intermediate dose, it comes down, but it doesn't come down to zero. And even with therapeutic dose anticoagulants, is still there, right? It just tells you that the hypercoagulability in COVID-19 is the not classic hypercoagulability we see and we treat with heparin and the anticoagulants. You know, it is something odd there, right? And it just means that we have to look for actually better options for stopping this hypercoagulability. The interesting finding from this meta-analysis is that whenever you have given pharmacological thromboprophylaxis or therapeutics, right, thrombosis and bleeding rates were not different, or bleeding rates, specifically bleeding rates, were not different, right? If you look at the guidelines, what do they say about thromboprophylaxis, really? And if you look at the guidelines, everybody has his own mind. Everybody is saying something totally different. There's very variable, inconsistent guidelines recommendation. In general, they say use the old guidelines. What the old guidelines say, use prophylactic. If you develop thrombosis or embolism, you use therapeutic. Okay, this is what the guidelines say, right? Although I have seen some actually people from the UK suggesting that we actually use a higher dose thromboprophylaxis dose and therapeutic in the ICU, right? Now, let's look at some studies, right? This is actually, in a study, they use intermediate dose anticoagulation and aspirin, and they looked at in hospital mortality, right? And they found, this is January of this year, right? They found that intermediate dose anticoagulation and aspirin were each associated with a lower cumulative incidence of in-hospital deaths, right? Suggesting that, using not the classic dosing, but intermediate dosing, like 1 milligram per kilogram, instead of the 40 milligram of Clexane, enoxaparin, you use 1 milligram per kilogram, then you probably would actually reduce, together with aspirin, you would reduce the incidence of in-hospital deaths, right? This is another study which looked at using therapeutic enoxaparin, right? And they found that therapeutic enoxaparin improves gas exchange and decreases the need for mechanical ventilation in severe COVID-19. So there is some signals that if you use therapeutic enoxaparin, you reduce the need for mechanical ventilation, right? Again, this is a study last December. Are there any negative studies? Yes. There are positive studies. There are negative studies. This is the inspiration study, a very big study, 562 patients, right? And they came up with the conclusion that they do not support routine empirical use of intermediate dose prophylactic anticoagulation. But there is a big caveat in COVID-19 patients. These are unselected patients. We know that our patients should be selected, right, based on the stage of the disease and the coagulation markers and so forth. You cannot do a study in unselected patients and come up with a good conclusion, because the COVID-19 does not behave like any simple other disease or similar diseases, okay? Now, what about the use of aspirin, another anticoagulant, right? Unfortunately, till now, I could not find any randomized control study on aspirin use. But I found actually 3 retrospective studies, all from the States, right? They all looked at patients who were COVID-19 patients and whether they have been on aspirin or not when they were admitted to hospital, right? And this is one of the first one of them, actually, this was, published very early on, right? Looking at patients 41 to 66 years of age, and there are 412 patients. They adjusted for 8 confounding variables, and they found that aspirin use was independently associated with decreased risk of mechanical ventilation, ICU admission, and in-hospital mortality. And no major bleeding. This is an important thing. No major difference in bleeding, right? And they came up with a conclusion: aspirin use may be associated with improved outcomes in hospitalized COVID-19 patients. This is actually a study, maybe if I remember correctly, this is probably 4 or 6 months ago, right? Another retrospective study, pre-existing aspirin prescription was associated with statistically and clinically significant decrease in overall mortality at 14 days, right? Less ICU admission, less mortality. Another retrospective study, an observational retrospective study, looking at aspirin use and mortality, right? In +1, right? This is only February of this year. Another third one there, right? Medicine, Baltimore, in an American study, another 232 participants, right? They came up with a conclusion that the 30-day and 60-day mortality in the aspirin group were significantly lower than that in the non-aspirin group, okay? So a very strong signal that aspirin use in patients with COVID-19 is beneficial, reduces mortality and reduces ICU admission. Now, let's come to another saga in this COVID-19. Now, anticoagulation one side, let's go to vitamin D. Now, I'm going just to share with you what the guidelines are saying currently. This is the NICE guidelines from the UK, National Institute for Healthcare and Clinical Excellence. They say, do not offer vitamin D supplement to people to prevent, and don't offer vitamin D supplement to treat. They say both. Don't use it for prevention and don't use it for treatment. This is the British one. So what the Americans do? What do Americans say? The Americans say there are insufficient data to recommend either for or against the use of vitamin D for the prevention or treatment, right? They are, what they are actually, neither here nor there, right? They're sitting on the fence. We don't say don't use and we don't say use. Now, these are the Americans, right? Now, let's see what the evidence is actually saying. Let's ignore these people, right? And we will look for the evidence ourselves and see, is there really evidence for it or against vitamin D, for the use or against the use of vitamin D. Now, this is a big observation study, systematic review again, meta-analysis, 43 observation studies, which was actually March, again, last month only. They assessed the association between vitamin D and risk, severity, and mortality for COVID-19 through a review of 43 observation studies, right? And they came up with one conclusion. Reduced vitamin D values resulted in a higher infection risk, so you are more likely to catch it. Higher mortality, if you catch it and you are vitamin D deficient, there is higher mortality. And more severe disease. If you have vitamin D deficiency, the disease is likely to be severe, right? And they said supplementation may be considered as a preventative and therapeutic measure. Now, the question is, right, just like the others, that we have prognostic markers or prognostic factors, right? We know the non-modifiable prognostic factors like age and gender, like males, and obesity and cardiovascular disease. But this is for now, at least for the first time, we have a modifiable prognostic factor there. We have a modifiable prognostic factor there. So let's see what's the next step. Why should vitamin D actually work in people with COVID-19? Now, let me just maybe highlight one important thing. Vitamin D is a steroid. Vitamin D is a steroid. It is not a vitamin. It's just been called a vitamin, but it's not a vitamin. It's a steroid hormone, right? It's a cyclical steroid hormone, okay? Now, it is known to have anti-infective, antiviral, right? It kills viruses, and it's also anti-inflammatory because there are several studies which show that it reduces IL-6. Now, IL-6 by itself is known to cause, is part of the cytokine storm, right? So mechanistically, physiologically speaking, vitamin D should be beneficial in people with, the viral infection, the hyperinflammation, right? Because it has antiviral and anti-inflammatory effects, okay? So mechanistically, there is some supporting evidence that it can actually be effective or useful, right? And as a matter of fact, when people compare the the pathophysiology of COVID-19, they like increased IL-6, TNF, increased gamma interferon, increased TH, they actually, and increased hypercoagulability. Surprise, surprise, they found that they almost exactly mirror the changes that are seen in vitamin D deficient patients, right? It's just exactly the same. It actually mirrors it exactly. And do we have evidence, right? These are the studies which actually I personally read, and I took out the data from them, right? There were 2 randomized studies and 2 observation studies. The randomized controlled trial, okay, this was the one done in India, and they gave only for mild non-hospitalized patients, they gave 60,000 units of vitamin D daily for 6 days, and they found that they were earlier clearance of the virus, and a clear reduction in the fibrinogen, suggesting an anti-inflammatory response, right? And I looked at the data for the CRP and D-dimer. They did actually trend down, but the trend was not significant, and maybe because the number of patients was not enough to show significance. Now, there was another randomized study, again for hospitalized patients, and they used calcifediol. Calcifediol is just a cholecalciferol with the 25 hydroxy arm, hydroxylation at the 25 position, right? So 25 hydroxy cholecalciferol is calcifediol. This is a big Spanish study, right? And they used this drug, which has actually, it's actually equivalent to really very high doses of vitamin D, like 20,000 or more. And they found that the ICU admission was less by 25 times. Patients who use calcifediol, 2% of them got admitted to ICU. The ones who did not use calcifediol, 50% were admitted to ICU, right? No deaths in these people and some deaths in these people, right? Again, when I looked in their tables for the CRP, ferritin, and D-dimer, the inflammatory markers, they were clearly less in the people who use calcifediol, but again, they did not reach statistical significance. Now, these are 2 studies which actually looked at the effect or the impact of COVID-19 infection in patients who were actually on vitamin D before admission compared to people who were not on vitamin D before admission. Just looked at that. And they found that if people were taking between 20,000 to 50,000 international units weekly pre-admission, they are less likely to die, significantly less likely to die, right? This is a British study. This is a French study which looked at 50,000 people taking 50 to 100,000 internationals every 1 to 3 months. And again, they came up with exactly the same conclusion, less severe COVID-19 and better survival. Very interesting. The British team actually looked at another hospital, another cohort of patients, and looked at whether they could replicate the findings in another cohort of patients. And they came up with exactly the same conclusion. So they actually managed to replicate their finding in a second cohort of patients, right? So these are 4 studies showing positive results. This is a study which is showing a negative result. Now, this was actually published in JAMA, right? In that study, they gave 200,000 international use of vitamin D, just one single dose, and it showed that did not significantly reduce hospital length of stay, mortality, ICU admission, or mechanical ventilation. And they came up with the finding, with the conclusion that they do not support the use of a high dose of vitamin D3 for treatment of moderate to severe COVID-19. But there are 2 problems are associated with this study. One is that the vitamin D was given a bit late because the average time from onset of disease is 10.3, right? Now we are going here into where? The hypercoagulability phase, right? We are inflammatory hypercoagulability, not the viral phase. So they might be giving it late. And we know that vitamin D is antiviral, anti-inflammatory primarily, right? Not anticoagulopathy. So it's probably they were giving it late. And the other problem with this study is they only gave one single dose. And you can see from the previous studies, these were giving daily or every other day. So suggesting that maybe daily or every other day is better than giving them one single dose. So don't delay it and don't give only one single dose. That was the message and probably why this study was negative, right? You know, some people did a meta-analysis of COVID-19 treatment studies, and they all studied, they found that if you give it early, you get 80% improvement. If you keep it late, you get 52% improvement, right? If you give it pre-exposure, you 40% improvement. And this is exactly what the British and the French have found, right? And so early treatment works better than late treatment. Okay, so 22 studies on COVID, on vitamin D and COVID-19, right? And if you look at the mortality studies, okay, 13 vitamin D treatment mortality studies, right? They all, if you give it early, 83% reduced improvement, so less mortality, 52% if you give it late, right? And if you give it pre-exposure, you get 62% reduced, 62% improvement, therefore 38% reduced mortality. So we have a meta-analysis of many studies. Actually, as a matter of fact, there were so many studies, a total of probably 74 studies on vitamin D. Nobody talks about them. But in essence, they are all suggesting that all these studies, 47, 2, 9 for early treatment, late treatment, pre-exposure, analysis outcome based on sufficiency, level in the blood, right? All of the studies are showing positive results, right? Most of the studies, 90% of these studies are showing positive results, 100% are showing 90. So the signal is very clear, strong signal, vitamin D, give it early, has a positive impact, okay? The majority of studies are showing a positive impact, right? And these are actually the risk ratio, and you can see it's almost 50% reduced, and this one, early treatment, you reduce by 17, so this is more than 80% reduction, right? So the evidence is very strong for vitamin D. And they, all in all, 74 studies were, went through a meta-analysis, and the findings were actually very supportive that vitamin D should be used in treating patients with COVID-19. Now, a third saga, doxycycline, right? Do we need to use doxycycline in our patients or not? Okay. Now, before we talk about doxycycline, whether it works or not, one needs to really mention, is it mechanistically or physiologically possible or plausible that doxycycline can actually work in patients with COVID-19, right? Now, the findings are that doxycycline has potential antiviral, anti-inflammatory effects, right? It does reduce the IL-6, and this was actually shown in dengue fever. People who are given doxycycline in dengue fever, their IL-6 came down, right? And we know IL-6 is important in the cytokine storm. And we know that it has inhibitory effects on the metalloproteinases, and which can impair viral entry, especially when combined with zinc. So doxycycline and zinc, right? So it mechanistically or physiologically, yes, it has some effect. Unfortunately, most of the studies, which actually initial studies, which looked at doxycycline in COVID-19, were not actually studies specifically, but they were like retrospective data. They looked at, for example, doxycycline of high-risk patients. These are COPD patients, and the result was positive. And then this is a group looked at 89 high-risk COVID-19 patients, and they also found these are elderly patients in long-term care facilities in New York, and they also came up that doxycycline actually mortality was only around 10%. And they looked, this is a case series of doxycycline and ivermectin, and I'll come back to this again, and a novel approach to managing. This is a study looking at lopinavir plus doxycycline. So there were actually some signals that doxycycline might work. Okay, but let's look at the most recent data on doxycycline. Now, this is the principal study, and many of you might have actually heard of the principal study, the platform randomized trial of interventions against COVID in older people. This is a British study, and they used two interventions, doxycycline or azithromycin, in the outpatient setting to see whether doxycycline or azithromycin has an impact on COVID-19. Now, look at the turn of events. Per protocol, randomization in the doxycycline arm was stopped for futility due to small probability of a clinically meaningful benefit. So there was a signal that thinks that doxycycline probably is working, right? That people are recovering more quickly at home or not needing hospital admissions. So they stopped the trial. They actually stopped the randomization altogether, right? The study said that there was at least around 1 day or less benefit and less than 2% benefit. Because, and I think if they just waited longer, maybe they would have actually came up with a bigger impact, right? Now they said they were going to publish the results of the doxycycline arm very soon. That was in 25th of January. They published the azithromycin arm, which came up very clearly, no benefit from azithromycin. People should stop using azithromycin altogether for COVID-19, right? The doxycycline arm, I'm still waiting for them to publish the doxycycline arm, right? I hope it's going to, be still showing some benefit. Now, doxycycline and ivermectin are an interesting combination, but let me just highlight what people are saying about the ivermectin, because this is the third drug, a fourth drug which we possibly need to consider. Right. The FDA said there are insufficient data for COVID treatment guideline panel to recommend either for or against the use of ivermectin. This was a change. Initially, they said we do not recommend, and then last January they changed, right? And they said we don't recommend for or against ivermectin. So they are, again, just like the vitamin D, they are, sitting on the fence, neither here nor there, right? The European Medication Agency against. Don't use ivermectin. This is the European thing. Now there is a big consortium or group actually of critical care physicians called the Frontline COVID-19 Critical Care Alliance. And they actually put a statement in March last month saying that they are warning world governments of the consequences of not deploying ivermectin for COVID-19. They're saying, in essence, what are they saying is that we have good evidence that ivermectin works in COVID-19. By all means, please use it, right? The whole world, the WHO says no. Again, coming back, is it mechanistically or physiologically, does ivermectin really do something? Ivermectin has been shown to reduce viral entry into the nucleus, and therefore it blocks an important step for viral replication, right? It blocks the interaction between the virus and the protein in the cytoplasm called importin. It also has some anti-inflammatory effects, but its major effect is that it does actually stop the virus, getting through to the nucleus. And this is the major, effect of ivermectin, plus others which are a bit more complicated, right? Now, this is a systematic review which was published a few months ago, actually 21st of January this year, right? And this is the no effect line. This is the no effect line, and this is the zero mortality, right? And you can see that most of the studies are actually suggesting that there is a lower risk of, deaths from ivermectin if you use it, right? If you use it early, it has better outcome than if you use it late, right? And even for prophylaxis, it has 90% improvement, right? You can see it's away from the no effect line, suggesting that ivermectin is really truly a good anti-prophylactic drug. But therapeutically, it was also working, showing that if you give it early, if you can actually achieve 84% improvement, right? Now, nobody actually liked this study, this systematic review. People didn't like it and didn't want to follow it. But then, surprise, surprise, again last month, there was another systematic review, again looking at vermectin. And they looked at the meta-analysis of 6 randomized studies using ivermectin, right? And they came with the conclusion that we observed a preliminary beneficial effect on mortality associated with ivermectin use, right? And the odds ratio was 0.21. Now, when you say odds ratio is 0.21, it means that you have reduced mortality by 80% or close to 79% exactly, right? And you can see this is the no effect line. This is the no effect line. Some studies are crossing, so there is no effect on mortality. Some studies are away, so suggesting that there is benefit, right? But interestingly, the majority were on the left side, suggesting that it does help actually. It does actually work. So in systematic review for 6 studies, which again pointing to the fact that ivermectin is probably effective in reducing mortality from COVID-19. Okay, and the study for prophylaxis again using 12 milligram weekly for 4 doses, or ivermectin drops daily, 24 milligram weekly, right? So there were several studies actually, 4 studies, which show that ivermectin prophylaxis does work away from the no effect line, favoring ivermectin as a prophylactic dose. Okay, the risk of reducing infection by 88%, significant protection. And the first meta-analysis, I'll just read you this. The probability that an ineffective treatment generated results as positive as the 35 studies to date is estimated to be 1 in 34 billion, right? Which means that the chances that the signal we are seeing is actually false is very, 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 very unlikely. Okay. Now, this is a study which was just recently again published a few months ago, right? And they looked at countries in Africa, 19 countries in Africa. People are using ivermectin there to stop onchocerciasis and so forth, right? And they looked at the COVID-19 and in these patients, in these populations, 19 countries, using ivermectin prophylaxis for onchocerciasis, and the ones who are not using ivermectin prophylaxis for onchocerciasis, right? And they found that this was significantly lower among the countries that are using ivermectin prophylaxis, right? And I just read you a very amusing statement. It says that a mass public health preventive campaign against COVID-19 may have taken place inadvertently. يعني بالصدفة كده هم لقوا نفسهم بيعملوا prophylaxis against COVID-19 with massive community is an attractive hypothesis, right? And obviously they wanted additional studies, right? But for me, do they need additional studies? The studies are already being done, but because they are done in Asia and South America, nobody's going to listen to them. They have to be done in America or Europe, right? And the frontline COVID-19 suggests a dose for ivermectin prophylaxis, right? For high-risk individuals, for example, healthcare providers, right? 1 dose today, 2nd dose in 48 hours, then 1 dose every 2 weeks, right? If somebody is exposed, you give them 1 dose today, you give them 1 dose today and 2nd dose in 48 hours, and that's enough, right? And they are suggesting an outpatient treatment protocol and a ward or ICU treatment protocol, right? I'll just conclude by sharing with you this, which looks like a highly effective combination, doxy and ivermectin, right? There are at least 5 studies which looked at the combination. On the whole, the majority of studies were actually positive. This is a double-blind randomized controlled trial with a good number of patients, 363. This is a double-blind randomized controlled trial. This is a case series. This is a single-blind randomized controlled trial. This is the randomized controlled trial. I didn't include the other observation studies, but on the whole, they found that there was a positive signal. For example, here in this study, right, that recovery time was 6 days in patients who received ivermectin compared to 9 days, right, and it was the studies were all actually suggesting a positive effect of ivermectin. Now we need to come up with, so what's next, right? What are we supposed to do next? We have all this evidence, right? We don't want to repeat the thrombolytic therapy saga, waiting for 5 years or more, right? Now there is one thing in evidence-based medicine is that we must provide effective treatment based on the best available evidence. This best available evidence could be an observation study, could be a case control study, could be a retrospective study. Better could be a randomized study, or even better, systematic review. Now, I've actually highlighted several systematic reviews, right? I actually tried to include mostly some systematic reviews on what works and what doesn't work. Now, if I look at these, right, probably if I look at the studies, then what will I say? Is that by all means, people in the community should be encouraged to use vitamin D, right? Because we have evidence that it reduces the severity, it might stop you getting infected, it might reduce the severity. These other things are not evidence-based, right? By all means, they might benefit, they might not. Once somebody has a viral infection or develops COVID viral illness, right, there are so many possibilities. Vitamin D is one, remdesivir, interferons, convalescents, right, ivermectin, doxycycline, right? These are possibilities. If they go into the hyper-inflammatory phase, we know that steroids work, tocilizumab works, there are other anti-inflammatory can work. But steroids and tocilizumab, possibly vitamin D also, right? Because it has been shown to reduce IL-6 in patients. When they go to the coagulopathy, we certainly have aspirins and heparins. Some might add the new anticoagulants. And so this looks the map of the groups of drugs that we should be using. It's important to note that as the disease comes in stages, we have to find or direct our interventions to the stage or the stages together. And that's probably what is showing that actually combination interventions are more effective than single interventions. So if a study is done on, for example, for example, doxycycline alone, it might not show benefit, but if you add it with ivermectin, it might show benefit. Or if you add it to steroids, it might show benefit. So it looks like we really have to treat our patients with a combination anti-COVID-19 medications, right? And depending on where the patient is in the ward or in the ICU or in the community, the treatment differs, right? In the community, yes, vitamin D, possibly ivermectin prophylaxis in high-risk patients. In the community, antivirals, vitamin D, monoclonals, I've added them. I didn't include the studies, but this is what happened, what was proven in America, that monoclonals or combination or dual monoclonals against COVID-19 for outpatients really work. And this is what Donald Trump was actually given, one of the monoclonals. Doxycycline and ivermectin are other possibilities, right? The combination of them, because several of the randomized studies used it in the community and it worked. Once they go into the ward, yes, steroids and vitamin D, tocilizumab, we have all these, possible interventions. By all means, aspirin, ivermectin, and doxycycline are other alternatives, which are available in Sudan. Convalescent plasma, anakinra, baricitinib, right? These might not work. Steroids, anticoagulation, tocilizumab, and ivermectin in the ICU. Right. The drugs which are we have shown reduced ICU admission are steroids, ivermectin, doxy, vitamin D, aspirin, heparin, remdesivir, and tocilizumab. These are possibly available, especially the phase 4, the phase 5, 1, 2, 3, 4, 5. Heparin, aspirin, vitamin D, and steroids, and ivermectin. These are available in Sudan, and they should actually be used to stop ICU admission, right? These are the people in Sudan for the training there. Limited resources, by all means, in the hospital, symptomatic viral infection, vitamin D and doxycycline ivermectin. They come to the ward, continue with vitamin D, start prophylactic heparin and steroids, and then aspirin, doxycycline, ivermectin. Aspirin is evidence-based, ivermectin is evidence-based. The combination ivermectin, doxycycline is evidence-based, right? Steroids and anticoagulants in the ICU, possibly therapeutic. There is a study which showed that ivermectin reduces ICU mortality if given to patients in ICU, right? So this is also an option in ICU. Now, if I would come with a proposed protocol, by all means, actually, in the community, I wouldn't actually hesitate recommending vitamin D, especially for high-risk patients. Patients above the age of 40 in the community, by all means, use 50,000 or 60,000 units weekly. It's very unlikely to harm them in any way, and it might actually reduce the risk of infection or reduce the risk of developing severe disease or going to ICU, okay? Now, if patients develop infection, especially they are high risk or they have severe symptoms, and they have high risk like 40 years of age, significant diseases, obesity, hypertension, I wouldn't hesitate actually recommending triple therapy for these people, doxy, ivermectin, daily high-dose vitamin D. I would not actually hesitate because there are enough signals in the literature, the evidence is already there. People can easily blind themselves from the evidence following what the guideline makers in the West, they want us to use remdesivir and tocilizumab. Okay, we don't want to use remdesivir or tocilizumab. We will use the cheap intervention that clearly have worked in patients with COVID-19. Right, I will certainly add aspirin if somebody is above the age of 40 or 45, but I will make sure that I give them a PPI. I will use heparins if they are hospitalized. I might use a slightly higher level of anticoagulation. I personally had a personal experience with a patient on enoxa 40 or 4,000 units and aspirin, and he developed pulmonary embolism while in the hospital. He's receiving both of them regularly, but he still developed it. So my inclination is possibly to go to a higher dose, right? The indications for dexamethasone are very clear. If the patient is hypoxic or their CRP is very high, right? Especially in the second week, the second week by itself is the inflammatory week. So if you see the CRP really becoming 10 times upper limit of normal, by all means, you go ahead and consider dexamethasone. So second week, high CRP, hypoxic patients, second week, by all means, consider steroids. By all means, make sure you give them some PPI to protect their stomach. And it's a problematic in diabetic patients, but one should really work on that. Prevent hyperglycemia, right? Ivermectin can be used to stop family outbreaks. One of the family members developed the symptoms, COVID positive, right? By all means, consider it. You can also consider it for healthcare professionals. And I think we have enough deaths from healthcare, from our colleagues, consultants, and other colleagues, especially high-risk patients. This drug is a very safe drug. Ivermectin is a very safe drug. The signals are strong that it is a preventative therapy. We should really make use of it to stop high-risk individuals from catching the infection or stopping, we don't want to see a family all dying from COVID, right? You need to monitor these people. You need to do blood counts, liver function, and CRP in D-dimer and serial X-rays. I cannot overemphasize, that you really need to look at the CRP in D-dimer serially. You cannot just do one test and ignore it, right? By all means, you do the CRP regularly and the D-dimer regularly to follow, right? CRP going up, D-dimer might be following it. The danger is when you see the D-dimer going up and the CRP is actually coming down, means that they are going into the coagulopathy phase. By all means, you don't have to check vitamin D level in all patients. Toxicity from vitamin D is very rare, right? You can advise people to monitor their temperature and blood pressure and pulse oximetry at home, and this is important, for patient education. Right, I'll just conclude now. I actually highlighted the network meta-analysis, which looked at 47 interventions and which ranked all the interventions, all these 47 interventions, right? The management of COVID-19 should be stage specific. And this is example of precision medicine. We should prevent as well as therapeutically. We should use vitamin D and ivermectin to prevent the disease and therapeutically to actually treat the disease. At the same time, we should look at the clinical picture and consider adding anticoagulants, and aspirin and heparin, covering all the stages of the disease. Antivirals seem to work pre-hospital patients, so we shouldn't hold them. We shouldn't wait until patients get ill. The very sad story about this statement is that we have Tamiflu, also Temavir we use for influenza, right? And the guidelines say if a patient develops symptoms suggestive of influenza, you start. You don't wait until they actually get worse. Why are they not doing the same for COVID-19? I just don't really know. Why do you wait until patients get worse and then come to hospital without starting an antiviral medication, right? Once people come into the hospital, the anti-inflammatory, anti-cytokine therapy are very important, and these are the ones which improve the outcome, right? We have enough evidence regarding the pharmacological therapies to significantly reduce mortality, and we should really make use of these. We need multifaceted combination therapy to improve prognosis in high risk or hospitalized patients. What we're missing is the evidence is there, but we are not implementing it, repeating the history of thrombolytic therapy in myocardial infarction. Right, this is the reference I use for the network meta-analysis, and the floor is now open for questions.
Thank you, Professor Matt. Session now you can open the door for questions just by pressing the reactions icon and use the raise hand. We have a question from Dr. Amir. I think she's asking about for how long should I use the anticoagulants?
Right. Well, it's a difficult question. I'll probably follow the D-dimer and the classic, risk factors. If a patient continues to have a high D-dimer, they're still bedbound or they're not back to their normal activity, I might actually continue. But these are all empirical. Nobody really knows exactly. One has to just do it patient by patient. But I suspect if you have a high D-dimer and you excluded, for example, a DVT or a PE, and then you probably can continue with anticoagulation. I currently have a patient actually, and it's very difficult. He's young, but his D-dimer doesn't want to come to normal, and I couldn't find any explanation. His CRP has normalized, right? The question is, shall I give him only aspirin or shall I give him also another anticoagulant? But these are difficult questions, and unfortunately, the higher the D-dimer, you will go for stronger anticoagulation. The lower the D-dimer, you probably go for a low level anticoagulation, and this is probably maybe a simple rule until we know more about what we should do.
Thank you, Matt. Do we have any question else? we'll provide you all with the record of this session, inshallah. So our YouTube channel. I think Prof, no further questions or comments. طيب اوكي، شكرا جزيلا بروفيسور عماد، ربنا يديك العافيه ان شاء الله في ميزان حسناتك. As I mentioned يبدو انه عندنا question. طيب my question about is there any trial for high dose of steroid like dexamethasone rather than 6 milligrams? لو سمحت دكتور سماح علي.
There is a study which was just recently published giving 20 milligrams of dexamethasone, and it seems to have worked very well. And there are also studies on very high dose methylprednisolone, like 1 milligram per kilogram twice a day. So really very high dose. And so it seems that even higher doses of dexamethasone do work, and possibly better than dexamethasone at 6 milligram. So by all means, still learning what is the exact or the best dose, but people can go higher, especially if they don't see a response from the usual dose.
Thank you, Professor Ahmad. I think we will stop here for tonight. Professor Ahmad, عندك final words before we finish?
Well, I really hope that people find it useful, and I hope that people will apply it to improve the outcome of our patients. And all the best, ومشكورين مرة ثانية على المشاركة.
شكرا جزيلا بروف عماد، شكرا جزيلا للساده الحضور الكريم. As I promise, inshallah, we'll find this record in our YouTube channel. We'll provide you through our Telegram channels with the link, inshallah. شكرا Professor Ahmad, and thanks again for all the audience. See you next week in another amazing exploratory online session. Till that time, take care. Goodbye.
Okay, بارك الله فيكم. شكرا جزيلا. شكرا.